I am Thatnursingprof and welcome to my channel. In today's video, we're going to be talking about perioperative nursing. Now, this is a large topic and I don't want it to be like information overload, so what I decided to do is actually break this up into 3 separate videos. So we're going to do pre-op, intra-op, and post-operative nursing. Otherwise, it's going to be really long and it's going to be a lot of stuff for you to remember. So this first video is going to focus on pre-operative nursing and what the nurse does preoperatively. So let's get into it. The first thing we're going to do is we're going to make sure that the consent is signed. Now, it is not our responsibility to talk to the patient about the benefits and the risks of the surgery they're having. That is the surgeon's job. And actually, they have to sign the consent. But what we can do is we can witness the consent. That is our legal role in getting a consent. So we need to make sure that it is signed and that we have it on the chart and ready to go, and then we can witness it because we were in the room when doctor explained everything. Review the patient's NPO status. So if this was a scheduled surgery, we planned this in advance. Hopefully they knew they were supposed to be NPO for at least 8 hours prior to that surgery. So we're going to ask them, when was the last time you had anything to eat or drink? And hopefully they'll say, nothing since yesterday. Ask about bowel prep when appropriate. Some surgeries will require, or procedures will require bowel prep prior. And so that's something either they do at home or they come into the hospital and wait a couple hours and have that done. Not every surgery needs this done. So if it's applicable, ask about it. Get a baseline of their vitals. Next, we're going to either review or draw their labs. So if their labs were previously done, this was a scheduled thing, maybe they met the doctor in the office or the clinic beforehand and they drew the labs there, we can review those results. Or we're going to draw brand new labs on this patient. Things we're going to be looking for commonly will be like their H&H, their hemoglobin and hematocrit, their starting out platelet count, their white blood cell count, and depending on the type of surgery, their electrolytes, like a CMP. So those are things we're going to check for preoperatively, so those are the labs we should draw. Give any meds preoperatively. So usually we're going to pump them full of IV fluids. If they come in scheduled for that procedure, ideally, it's 2 hours before the surgery, and that's enough time for us to do all of these things, and it's enough time for us to get a couple bags of fluid in them. And then antibiotics. Those are also given pretty commonly, like a prophylactic antibiotic prior to surgery. Sometimes we might even give certain medications like anti-anemics or steroids or things like that, whatever the doctor may have ordered. Sedatives, that kind of thing. Those are pretty common meds given preoperatively. We're going to insert an IV and possibly insert a Foley catheter depending on what kind of surgery it is. If they're going to be unconscious, they're going to have general anesthesia, they're definitely going to need an IV and an indwelling Foley. We're going to make sure they remove all jewelry, makeup, nail polish. If they have dentures or a hearing aid, glasses, contact lenses, we're going to ask them to remove those things prior to surgery. And then we're going to put family member or somebody in charge of these items so that they don't get lost while patient is in surgery. And then we'll direct that family to the waiting area. There's going to be a designated area for them to wait, and throughout the procedure we're going to come back and update the family members on what's going on. Of course, just like everything, we have to do a baseline head-to-toe assessment. We need to know what they're starting out like. Skin prep may or may not be involved. So skin prep can include washing certain areas of the body with antimicrobial soap or shaving certain areas of the body, depending on where they're having the surgery. Of course, the big one, right? Reviewing allergies, especially to things like latex. Allergies, and then their current medications. And then I've made a list here of some medications that are considered high risk for surgery. So those include aspirin and NSAIDs. Sometimes people take those every single day. So we need to know, is this something you take every day? So aspirin, NSAIDs, antidepressants, anticonvulsants, blood thinners or anticoagulants, steroids, and then, of course, certain vitamins and herbal supplements. So, like ginkgo has a really bad reputation, garlic has a really bad reputation when it comes to bleeding. And that's a big risk factor to have during surgery, right, is the risk for bleeding or hemorrhaging, bleeding too much. So we need to know, are those vitamins and herbal supplements that they're taking? We may need to do a full admit on this patient depending on what's going on with them. We're always going to do baseline vitals, baseline head to toe, because we've never seen this person before. But if they're having like an outpatient surgery or like a scheduled day surgery where the nurse in the clinic or in the surgical center like calls them at home the week before and starts asking them all the questions about like their health history, their surgical history, their family history, all of those things you ask in a proper admission, then you don't need to do that as the pre-op nurse because it's already been done. If it's not that kind of surgery and you don't have the luxury of all that stuff being done ahead of time, you might need to do it now in the preoperative stage. We need to review their health beliefs or religious beliefs prior to surgery because a common thing that can happen during surgery is blood loss, and so we will give a blood transfusion during the operation or right after. And if this is the type of person who doesn't believe in that and doesn't want to have a blood transfusion, we need to know that ahead of time so that we don't just give it to them without their consent when maybe they're unconscious and can't tell us no. So that's something really important that we want to review prior. Of course, everybody who's going to have a procedure is going to be considered a fall risk. So we're going to have side rails up, bed in the lowest position, they're going to have their fall risk bracelet on. Everything is going to be considered a fall risk precaution. So making sure they're safe. And then the stop bang, doing a stop bang. I'll do that here when I'm done with this because I'll make the chart and tell you exactly what a stop bang is. It's to assess for people who are at risk for sleep apnea, who are at risk for complications during surgery because of it. Of course, this is the time they're going to be conscious, right? They're going to be able to listen to us, so we're going to do a lot of teaching during this time. So what are we teaching them? We're teaching them about what we're doing as we're doing it. So I'm inserting this IV because we need to give you medication during the procedure, right? So explaining what you're doing, why you're doing it, what will happen during the surgery. So if they're going to be unconscious, letting them know what's going to happen, giving them a general idea. If they're going to be awake during the surgery, letting them know, okay, you might feel this, you might hear this sound, that kind of stuff. Assess the patient's level of understanding. This happens a lot. Doctor will come in, they'll get the consent, they'll explain the risks and benefits and do everything, and then they'll walk out of the room and the patient will look at the nurse and say, I have no idea what they just said to me. I don't know what I just agreed to have done. And that's bad, right? That's dangerous. So you always want to assess, what do you understand? What do you think is going to happen? Involve the family, right? Because of course there'll be family. They're going to want to know what's going on. They're going to have questions. The patient might be like, I get it, I'm good, I don't have any questions. But the family will have 100 questions, right? So be prepared to answer any questions that are appropriate. Don't forget to address the emotional aspect of surgery as well. Most people are nervous about it, right? They're nervous going in, they're afraid, they might think like, oh, what if I never wake up? Like scary stuff like that, right? So asking them about how are they feeling and letting them go through those emotions. Ask their coping strategies. And then inquire about their own self-concept and body image, especially during like certain surgeries. So like if you're having something like a colostomy placed, right? Obviously that's going to alter the way you look, right? And that can alter your body image and how you feel about the way you look, right? So don't forget about stuff like that. That's important too. So what groups of people are at risk? Those with extremes in age, so the very young and the very old, so like little children, babies, and the elderly. Those who are obese, the higher the BMI, the higher the risk you have. And then those who have a comorbidity or some other chronic disease, like a diabetes. Diabetes is huge when it comes to surgery. When you think diabetes and surgery, think post-op infection. They are at high risk for that, and I know I ask questions about that, ATI asks questions about that, and I'm sure NCLEX will ask questions about that too. So when you think diabetes and surgery, think post-operative infection. That is huge. If this is a scheduled surgery, something that's been planned far in advance, and you are doing that admission stuff like over the phone, Some things you might want to do or bring up is asking them to stop certain medications like blood thinners, asking them to stop smoking, right? Alcohol use, substance abuse, that kind of stuff. Some surgeries, they require the patient to lose weight to be eligible to get the surgery. So it's not like everything's an emergency and we're doing it today, right? Some of these surgeries are planned and we have time to ask the patient these sorts of questions. When they're not planned, when they're emergencies, right, which in OB, we're in emergencies all the time, right? When they're not planned, you still got to do all this stuff. And that is why teamwork is really, really important. So one nurse will come in and do the IV. Another nurse will come and do the consent. Somebody else will put in the Foley catheter, right? And we all work together. Now let's talk about what a stop-bang score really is. Now let's talk about how to do a stop-bang assessment. Really, it's just a couple of yes or no questions. So the S stands for snoring. Do you snore, yes or no? And when I say snore, because a lot of people snore, right? When I say snore, it's like, do you snore loud enough that somebody can actually hear you in another room? That kind of snoring. Tired. Do you feel tired or drowsy or sleepy throughout the day? O is for observed. So has another person, your bedmate, your spouse, your partner, whatever, observed you stop breathing while you were sleeping? P is for pressure, so blood pressure. So have you been treated or are you currently being treated for blood pressure problems right now? Are you currently on a blood pressure medication? BMI greater than 35. Age over 50 years old. Neck circumference greater than 40 centimeters, and then gender, males. So men are at higher risk for developing complications during surgery simply by being men, as are people who are older and who have a higher BMI. So this is the stop-bang score. It's pretty easy to figure out. It's just a bunch of yes or no questions that we ask the patient prior to surgery. Now let's talk about the different types of surgery. When we talk about the different types of surgeries, we usually put them into 3 categories. The reason they're having it done, the risk involved, and in the sense of urgency. So let's talk about them in more detail here. So under our reason, we have diagnostic. So a diagnostic surgery is done to identify the presence of a disease. A very common one is a biopsy. An exploratory surgery is to check the extent of that disease, and a common one of those is an exploratory laparotomy. An ablative surgery is the removal of an organ, so commonly that could be like an appendix removal or a hysterectomy or something like that. Reconstructive surgery is the repair of an organ, so there's some sort of damage to the organ. Constructive is a repair of a congenitally damaged organ. So usually this is done in babies, but sometimes later in life these things can be done. So they were born with something wrong to one of their organs, like maybe their kidneys or something like that, and then they needed to have a surgery to repair that. Palliative surgery is done to alleviate signs and symptoms, okay? Palliative surgery is not curative surgery. It's not going to all of a sudden make them better, but it's going to make them feel better. It's going to help reduce their signs and symptoms and the things that they're dealing with. So it's a nice thing, and an example of this is to maybe remove cancerous tissue. It doesn't mean you're necessarily going to be cancer-free, but whatever issues that tissue is causing in your body, like certain pains and things like that, hopefully that will be aided in removing this tissue. It's going to help them feel better. Cosmetic surgery, this is what they call plastic surgery, right? So this is done to improve one's appearance. So these are the reasons we can do surgery. These are the type of surgeries. It can also be risk related. So a major surgery versus a minor surgery. So a major surgery would be like a cabbage or like a heart transplant or something like that, right? That's a major surgery where they're going to be in the room for a long time. It takes a lot of hands. It's, it takes several hours. It's very dangerous. We're touching your organs, that kind of stuff. Major surgery. A minor surgery is going to be the opposite. Usually it's more superficial, it's less invasive, and it takes a shorter amount of time. Lower risk. So major surgeries are much higher risk. Minor surgeries are much lower risk. And then finally, the urgency of the surgery. That's our final category. So if it's an emergently needed surgery, we need to do it right now, immediately, because if we don't do it, this person's either going to die or they're going to lose a limb. So to save life or limb, that's what we say. An urgent surgery needs to be done sooner rather than later. And when I say sooner rather than later, I say as soon as possible, roughly within about 24 hours. Okay? So it's not like I'm going to die right now if you don't do this. But I might, or there might be severe complications if you don't do it soon, maybe within the next couple of hours, that kind of thing. And then elective surgeries, elective kind of throws people off because you hear elective and you automatically think cosmetic, right? You think, oh, they're the same, right? No. So elective is simply something that can be scheduled. So this might be a surgery that is necessary or not necessary. So cosmetic surgery, plastic surgery, can be an elective surgery. You don't need to have it, but then getting your tonsils removed, you may need to have that done, right? You just don't need to have it done within the next 24 hours or right now, right? So an elective surgery is one that you can schedule in advance. Okay, so this is the first video in the series of 3. This was pre-op. The next one is going to be intra-op. Thank you so much for watching. If you have any questions or comments, please let me know. And if not, I'll see you on the next one.